Hello, good morning, good afternoon, good evening, wherever you are. I do apologize for the delay. I was meant to go live at 6:30 p.m. Eastern Standard Time, 10:30 a.m. here on a Sunday, Sydney, Melbourne time. So I do apologize for the delay. I had to attend to a couple of clients, so my apologies. Now, let's get right into this today, so we are not wasting any time because I'm running late. Just very quickly, some housekeeping issues. I will have some questions prepared today that we got during the week. But if you have any questions as well, just type them into the chat pad, or you can dial in live on the show. I've got about 40 minutes. I was planning to go for an hour at least, but I got delayed. I do apologize. What makes me qualified to answer questions on this live show for families in intensive care? I have worked in intensive care for over 20 years in 3 different countries. I have worked for over 5 years as a nurse unit manager in intensive care. I've been consulting and advocating for families in intensive care all around the world for the last 10 years. And I'm also running an in-home care nursing service, intensive care at home, where we send intensive care nurses into the home for predominantly long-term intensive care patients, mainly adults and children that are long-term ventilated with tracheostomy, but also non-invasive ventilation such as BiPAP, CPAP, such as home TPN, or otherwise medically complex clients that are at risk of long-term stays in ICU. And you can find more information at intensive care at home for that. So, but let's dive right into the first question today. That is also the topic of today's YouTube live. My husband is in ICU with Covid pneumonia for 7 days. How can he stay off the ventilator? So that's today's topic. And I've got an email here from a reader, and it is Arlene. Arlene writes in, "Hi Patrick, my husband, age 69, recently got RSV. When that was resolved, he went to a rehab facility for occupational therapy and physical therapy, as he has Parkinson's disease. A day after he arrived there, another patient came down with COVID, which then spread to other patients, including my husband. He was then transferred to the hospital for care and was fed by the nurses or aides and came down with a bad case of aspiration pneumonia. He was then transferred to the ICU last Friday night, which was January the 28th. He's on a ventilator and feeding tube and received 5 days of antibiotics. He was improving and tried to see if he could breathe with a CPAP while still connected to the ventilator. He was only able to for 2 minutes last Tuesday, but for almost 2 hours on Wednesday. Imaging showed some improvement in his lungs. They stopped giving him antibiotics on Wednesday, and then he developed a low-grade fever Wednesday night, which got worse over the next few days, and his white blood cell count has been going higher. They don't know why he has a fever and higher white cell count. Could it be because they stopped the antibiotics last week too soon? They put him on antibiotics last night, which are broad spectrum." Just reading this again, his white cell count has been going higher. I don't know why he has a fever and higher white cell count. Could it be because they stopped the antibiotics last week too soon? Yeah, definitely, that could be why. And now they are starting again with antibiotics, especially if the white cell count is high. The first answer to that question is yes, they might have stopped the antibiotics too soon, not clearing the infection completely, and that might have simply been too early. Arlene continues, "They tried a breathing test today and he failed. The doctor told me today that they'll try again tomorrow and I think again the next couple of days. He said if he can't breathe on his own, they're thinking of possibly doing a tracheostomy. I read about this procedure and I'm afraid for his life. If he would have to have it, I understand from what you've said in your video, the best way is to have him at home with 24-hour expert help like intensive care at home. Is there a way to wean him off the ventilator and not have him to have a tracheostomy. I'll be leaving shortly to see my husband again. I would appreciate any help, and if you require more details, please let me know. I want to do the very best I can to save my dear husband's life. Also, do you think they should give him a second round of antibiotics a few days until it helps my husband fight whatever is going on, and perhaps he will then be able to do better with his breathing? Okay, Arlene, thank you so much for writing in, and let's answer the first part of your question. Have they stopped the antibiotics too early? Possibly, but you're also making reference obviously to COVID, and COVID is not a bacterial infection, it's a viral infection. Now, what we've seen now with COVID, we have seen a lot of patients that start having COVID and then they end up with a bacterial or a fungal pneumonia as well. So the first question to me here is, is the pneumonia, is it quote unquote only an aspiration pneumonia, or is it potentially a COVID pneumonia? You haven't shared that, but I do believe this is a question you need to ask to the intensive care team. Now, the next question is, have they done a sputum sample of his lungs, which they probably could have easily done by suctioning him with a breathing tube? So, have they diagnosed him with the right pneumonia, i.e. bacterial pneumonia, COVID pneumonia, fungal pneumonia, who knows? Or is it an aspiration pneumonia that has now developed into a bacterial pneumonia? If so, what bacterium is it? Once they found the bacterium, use the right antibiotic to target the bacterium. So that would be my first question. If it's COVID pneumonia, then they would need to follow their protocols for COVID pneumonia, which is often remdesivir, steroids, and so forth. You haven't shared what medications he's on. And this is what I keep saying over and over again, that the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights. And they don't know how to manage doctors and nurses in intensive care. So, there's a lot of information that's missing here. But, let's just look at the information that's there, which is obviously, they have given antibiotics. They potentially stopped them too early. We don't know. They may have stopped the antibiotics too early. They may not have given the right antibiotics. Obviously, white cell count is up, and as long as white cell count is up, something's not right. As long as white cell count is up, there is an infection. As long as there's a temperature, there must be some sort of infection. So they do need to do the digging, what's really going on, but they should also send a urine sample. They should take blood cultures, and diagnose from there. Now, as far as weaning off the ventilator and avoiding a tracheostomy is concerned, it's really a matter of treating the pneumonia first, right? If he can't pass the spontaneous breathing trials yet, if he can't pass the CPAP trials yet, is he still sedated? You haven't shared any of that, whether he is on sedation or not, right? In order to wean someone off a ventilator, you need to take them out of the induced coma and wake them up gradually. You need to stop sedatives. He might be on propofol, he might be on Precedex, he might be on Versed or midazolam, right? He might be on morphine, he might be on fentanyl for tube tolerance. And that all needs to come off, and then he needs to gradually improve or increase his efforts to breathe independently. Once that's done, or once he can move towards breathing spontaneously and independently, that's also when things like physical therapy kick in, when physical therapists or physiotherapists need to start doing breathing exercises with him, coughing exercises. That all needs to go hand in hand with treating pneumonia with the right antibiotics, or with, if it's a COVID pneumonia, treating it appropriately. Now, the other thing that you haven't mentioned yet is, I haven't mentioned how much oxygen he's on. He needs to be on oxygen requirements less than 40% FiO2. He needs to be on a PEEP less than 7.5. He needs to be on pressure support less than 10 millimeter per mercury, 10 centimeters per water. So again, this is where specialist or specialized intensive care knowledge comes in, where people come to us all the time and they say, well, can my loved one come off the ventilator? And our answer to that is really that it depends. You can now see that we need to look at so many things, starting from ventilator settings, starting from what pneumonia are we dealing with, what medications is he on, what are blood results. Now, the other thing that I want to focus on here is arterial blood gases. Anyone on a ventilator should have at least intermittent arterial blood gases, so one can find out how well is ventilation in the blood. How adequately or how adequate is ventilation for oxygen levels and carbon dioxide levels in the blood. That's what an arterial blood gas is telling you. Other things that you haven't shared is how awake is your husband? Can he open his eyes? Can he squeeze fingers? Can he follow commands? That all helps him in getting off the ventilator. Does he have a good, strong cough? Those are things that are really important in situations like that. Now, at the time of you contacting me, it would have been around 7 days of him being ventilated from what I'm reading. Now, when you look at the timelines when someone should have a trach, right, it's about 10 to 14 days of mechanical ventilation with a breathing tube. Your husband is not there yet. And, it would be good if you can avoid the trach, because a trach, is often a long-term thing. It might stay in for a couple of weeks. It might stay in for 2 months. Some patients have the trach for the rest of their lives. It's really hard to predict, But one thing is clear: wherever you can avoid the trach, you need to avoid the trach. Okay, and I've just given you a quick breakdown in terms of what needs to happen, right? So one of the challenges when someone is on a breathing tube or an endotracheal tube is really tube tolerance. It's a vicious cycle because many patients need to be in an induced coma on sedatives and opiates in order to tolerate the breathing tube or endotracheal tube. Now, the longer someone is on sedatives or opiates, the lower chances are to be able to avoid the trach, because when someone is in an induced coma and is ventilated, deconditioning is a real thing. Muscle wastage is a real thing, right? Every day that someone is in an induced coma, it means there's muscle wastage, including breathing muscles. That means when you wake someone up, their breathing muscles and other muscles are weak, and they're struggling to be able to wean off the ventilator. That's why mobilization, breathing exercises, coughing exercises are so important in order to aid the process getting someone off the ventilator. I hope that makes sense. The time in an induced coma should be minimized to the absolute minimum. Other issues that arise from this are, especially if someone is on midazolam/Versed, it's a benzodiazepine and it's addictive in nature. The longer someone is on midazolam or Versed, they potentially go through a withdrawal process when you wake them up, when you try to remove the midazolam or Versed. The same with morphine and fentanyl. They are highly addictive in nature. The longer someone is on morphine or fentanyl, the higher the risk that they need to be weaned off those medications because they're now addicted to it. And they might go through withdrawal if you take those medications off. So it's really a catch-22, you know. But the process needs to be started, because even though you can take someone off sedation theoretically when they have a tracheostomy, what we are seeing at the moment is not all intensive care units follow best practice, and not all intensive care units take patients off sedation or opiates when they have a tracheostomy. But that's the whole purpose of a tracheostomy. Take patients off sedation, take them off opiates, start mobilizing them, start weaning them off the ventilator, beat more aggressively, because they don't need the sedation and opiates when they have a tracheostomy, right? So, Arlene, I hope I've explained to you how a tracheostomy can be avoided. Now, God forbid, if your husband needs a tracheostomy and can't be weaned off the ventilator, you should look at intensive care at home as a next option. Right? With intensive care at home, we take adults and children home for ventilation and tracheostomy, including long-term weans. We are currently operating in all major capital cities in Australia, and you should be contacting us for intensive care at home. If you are in Australia, you haven't shared your location, but even if you are in the US or in the UK, you should contact us. We are able to set you up with the right people in those countries, or we are able to advise you with strategies, you know, how to wean off the ventilator. So you should contact us one way or another. Okay, let's move on to the next question. Question from Carla, and Carla says, my mother had brain surgery 3 weeks ago. She's still in ICU, and they want to remove the ventilator tomorrow and use nasal oxygen. I'm wondering, what are her chances of survival, and move her to a ward? Can we ask for home life support options? Great question. Look, it's a very basic email in terms of what we need to know in order to really advise you. But I also know that it's very difficult for families in intensive care to ask the right questions, which is why I'm doing these live streams, so you can get as much information about intensive care as possible, and you can really understand what's important and what questions you should be asking. But I guess the good news here is this: they want to remove the ventilator tomorrow and use nasal oxygen. Well, that's very good news, right? Assuming it's not a quote-unquote one-way extubation. What's a one-way extubation? A one-way extubation is that patients have the ventilator and breathing tube removed without any desire to re-intubate a patient, and that can often be an end-of-life situation, right? So someone, maybe all parties agree to a palliative care situation, right? And ventilation is removed with the goal of having end-of-life care, then that's okay, but you're not alluding to that. So I would imagine that in your situation, or in your mom's situation, that she has the breathing tube removed, she will have nasal oxygen, and God forbid, if that fails and she's struggling to breathe, she would have the breathing tube reinserted, and she would need to be reintubated. I assume that is the case there. You haven't alluded to it otherwise. So then you're asking, what are her chances of survival, and move her to a ward. Again, assuming that they've ticked all the boxes, that she can be taken off the ventilator, her chances of survival should be good. You know, it's when you take someone off a ventilator with a breathing tube, you have a limited time window to do that, and you need to choose the right time so that you maximize chances that your mother, or any other patient for that matter, won't get reintubated. You know, you need to really time it well. You need to prepare for it, you know, and you need to be certain that once you take out the breathing tube, that someone can manage without the breathing tube, right? Can we ask home life support options? Similar to the previous question from Arlene, Carla, home care options are always there. I guess, you know, I'm not sort of, I don't know enough about sort of lower acuity home care. I'm sort of more in the space of higher acuity home care, because obviously we provide intensive care at home. If she can be moved to a ward and she can breathe independently, and hopefully she can go on to rehab with her brain injury, right? You shouldn't need home life support options. Life support at home to me means a ventilator for a tracheostomy or non-invasive ventilation such as BiPAP or CPAP or home TP, and those are home life support options, really. And it doesn't sound to me like your mum needs that. You haven't shared how severe her potentially brain damage is, or just because she had brain surgery doesn't necessarily mean she has brain damage. You haven't shared any of that, but I would hope that once she's off the ventilator, she can move to a ward and then she can go home. Or maybe she needs to do a step in between, which is rehabilitation. But, then she shouldn't need life support. So then either she can go home with low level of support or she can go home independently. I hope that helps. And again, if you are in Australia and you do need home care especially for long-term intensive care, you should contact us at intensivecareathome.com, and we can help you there. Next question from Greg. Greg says, I found your website online and I thought I would give it a try because I want to get answers. I'm desperate for it. My mom has COPD. At home she has oxygen, but not all the time. She was currently using it only at a level 2 liters of oxygen. She was admitted into the hospital for pneumonia and now is on a ventilator. Today makes 1 week on the ventilator. They are already talking to me about a tracheostomy. I feel this is too soon. I would like some guidance. Okay, you definitely contacted the right place, that is for sure. Your mom has COPD, and now they're already talking about a tracheostomy after today's 1 week. Okay, similar to Arlene's question earlier, generally speaking, a patient can stay on a ventilator with a breathing tube for about 10 to 14 days before a tracheostomy should be considered. So you are now at day 7. It sounds like you still have some time. Same questions need to be asked then previously to Arlene, where, is your mum still in an induced coma, right? If she is in an induced coma, can they take her out of it? What happens if they take her out of it? Is she potentially fighting against the ventilator? Why are they talking to you about a tracheostomy? They should be talking to you about how to avoid the tracheostomy, right? That should be your question. Okay, that should be your question. Can they avoid a tracheostomy? Can they wean her off the ventilator? What ventilation settings is she on? What medications is she on? What are blood results? What are arterial blood gases? Especially with COPD. Is she retaining CO2? COPD sometimes means that patients have a high CO2 level, high carbon dioxide level, that may stop her from weaning off the ventilator. I'm not sure. You need to ask that question. You need to ask those questions, more or less, And then if they do a tracheostomy and you are giving consent to that, assuming you are the power of attorney, then the question is, what are the predictions to wean her off the ventilator? Then how long would it take? It's much better to do it now, right? Much better to do it now than when they have it, when your mom has a tracheostomy. Okay, so go back to them and say, how can we avoid the tracheostomy? So I hope that helps. And one of the challenges here might be really with COPD. One of the questions you really need to ask is she retaining CO2? That is really one of the questions you need to ask. COPD means she might be a CO2 retainer, where oxygen doesn't necessarily help. I know she's on oxygen at home. you know, but oxygen doesn't necessarily help with COPD, or not high levels of oxygen anyway. Okay, I hope that helps. I can see there's a question from Jose. Does edema take a long time to subside? The kidney function is okay. Okay, so if there's edema and kidney function is okay, it could be a matter of albumin being low, right? It could be a question of albumin being low. Is your loved one immobile? Okay, is your loved one immobile? That's another question. If your loved one is immobile for long times, then there's also the issue around immobility often causes edema, right? So I hope that helps to answer your question, but I don't have a lot of context with your question. You know, you're saying, does edema take a long time to subside, even though kidney function is okay? You know, if you could help me, Jose, is your loved one doesn't move much? Yeah, had a stroke, doesn't move much. Yeah. I'm not too surprised there that if there's not enough movement. So another thing that you could start doing, and I'm not sure whether you are in a position to do it or not, is physical therapy, movement, right? Movement might really help. You know, we have a lot of clients at home that are all immobile, but with physical therapy, you know, you can avoid some edema, you know. Also, other things that might be happening too is you got to look at fluid balance. You know, maybe your loved one is having a fluid balance that is out of whack. So what I mean by that is maybe your loved one gets 3 liters in a day, but it's only putting 1.5 liters out. Right? So that could also be something that needs to be looked at in terms of what's the fluid balance like. I hope that makes sense. Because if the fluid balance is out of balance, then you'll also have edema. Right? Does your loved one get regular blood tests? I.e., again, albumin levels would be the first thing that comes to mind. If albumin levels are really low, that also causes edema. Your loved one might need an albumin infusion, or potentially a change in nutrition. Okay, I hope that helps. Jose, do you want to add in? If you don't want to add on anything else, I'll move on to the next question. Okay, the next question is, I learned from your videos for 3 days. I requested spontaneous breathing trials. They're ready to discharge, but they're not doing any spontaneous breathing trials. My dad is at a PEEP of 5, but his FiO2 ranges from 30 to 40%. They did one today and he was off for 3 hours. It was on CPAP mode and he becomes tired. They will do another spontaneous breathing trial tomorrow, but thanks for your channel and website. I learned and hold ICU accountable to continue treating my dad and not hold back treatment. I also demanded the echo/ultrasound, and the doctor was telling me he's okay for the past 48 hours. And we did one on February the 5th, and I told him I want another one before you discharge him. I have been trying to discharge him since 28th of November last year. I'm in the United States. Thank you for the information you share with us. And that is from Rosa. You haven't shared whether your dad is having a tracheostomy or a breathing tube. I would imagine he's having a tracheostomy, given that you are referring back to November 28th, and you've sent the email this week. So let's just assume your dad has a tracheostomy, you know, again, is he getting mobilized? You know, the number of times we get emails like this, and when we actually talk to clients or prospective clients and we ask them, is your loved one getting mobilized? They say no. You know, and you can't wean someone off the ventilator without a tracheostomy. It's just not without mobilization. It's just not happening. I've never seen it. Just not happening without mobilization. That is number one. That is number one. So, you know, it's good that his PEEP is at 5. It's good that his FiO2 ranges from 30 to 40%. It shouldn't be any higher than 40%, because very rarely can you get someone off the ventilator with more than 40% of oxygen, right? And when you're saying, you know, he was on CPAP mode is a spontaneous ventilation mode, but it's not off the ventilator. You know, for him to be off the ventilator, they need to stop CPAP and he needs to breathe spontaneously. You know, and again, they need to start mobilizing your dad, because it doesn't sound like that's happening. And yeah, range of motion for say is mobilization or physical therapy. Yeah, needs to happen. Range of motion might help with edema, and it might also help with weaning off the ventilator. You know, either one. Again, any mobility is fine. It's good. It's a good thing. So what exactly is mobilizing? Mobilizing is getting someone out of bed, sitting them in a chair, right, every day. And that is possible even for someone with a stroke. That is possible even for Rosa's dad. You know, you can, unless there's a contraindication, the contraindication really means like someone has a fracture, you know, waiting for surgery, you know, that could be a contraindication for mobilization, you know, or for range of motion exercises. But if there's none of that, if there are no fractures, you know, there's nothing stopping anyone from getting mobilized. Right? The thing that's stopping often people in ICU is the mindset of the staff, and potentially staff shortages, but you know, it's patients need to get the best outcome. Right? So coming back to Rosa's question, again, you are referring that you've demanded an echocardiogram, but you're not sharing what echocardiogram. Is it an echocardiogram for the lungs? Is it an echocardiogram for the heart? For something else, for the tummy region? You haven't shared why. You know, and again, if your dad can't come off the ventilator, you should contact intensivecareathome.com to get him home. Right, that would be your next best step, Rosa. So go to intensivecareathome.com and contact us there, because it sounds like your dad is struggling to get off the ventilator, and then we could look at home care. So I hope that helps. Jose, just quickly coming back to your question, range of motion is part of mobilization, but again, mobilization in the best sense is sitting someone on the edge of the bed, getting them in a chair. You know, that's all possible. A good ICU, a good rehabilitation center, a good hospital has special chairs for their patients that are highly vulnerable, and they can get out of bed. Again, the only contraindication really is any fractures. Everything else is just a poor mindset why people are not getting mobilized. Okay, I've got 5 more minutes left. I'll do one more question. If someone wants to type in a question, that would be great. If not, I'll have other questions from emails. I just need to quickly moisten my throat. So I'll just have another question here from an email. Unless someone wants to ask a question. And And that is an email from Anna. Anna says, your videos are very encouraging, but my son didn't make it. The doctors never intended to wake him up. They lied, avoided my questions, and finally at 1 a.m. in the morning, after doing well for days, his heart mysteriously stopped after 3 attempts of CPR. His heart would beat again, but the doctors kept stating with confidence it would stop again, and it did at 4:12 a.m., which was exactly 3 hours later. The time they stated and the hospice shot would take for the heart to stop. I'm very sorry, Anna, about this, but there is another email from you that I think gives more context. They took over and overruled and denied all transfers, and my son died in ICU. He was in a medically induced coma from 20th of November 22 until the 9th of January 23. He was still paralyzed and sedated, but his heart was beating, and beating strong despite their effort, and over accepted with high PEEP and pressure from the ventilation machine. It kept normalizing itself, and tears would come down his face when I talked to him, and I believe they did hospice to stop his heart without family consent. Oy, Anna, that's very sad to hear. Look, I can't say what happened without having, looked at medical records and so forth. I guess what does stand out here to me is you should not have given into hospice in the first place. Normally if you go to hospice, you need to give consent as a power of attorney, and you shouldn't have given consent to that, because the alternative to that is really treatment. You haven't shared how old your son was, but it sounds to me like he was very young. And again, it comes back to that the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. It sounds to me like that has been part of this situation, because if you had known your rights, you would have never agreed to hospice, assuming you are the power of attorney. Now, in regards to his death, again, I wouldn't know what happened exactly, why his heart stopped at a time they were predicting. All I can assume here is that potentially they were timing his death by removing, or they were trying to time his death by removing life support, but you should have never given consent to that. Again, assuming you are the power of attorney. But the only way I can help you with this is really by looking at medical records. Me and my team can look at medical records and find the answers for you. So I hope that helps, and I'm terribly sorry, Anna, about what's happened here. It sounds like this could have been avoided with the right strategies, and this is why I'm saying no one can contact us early enough. No one can contact us early enough. I understand no one's sitting at home thinking, oh, what would I do if my loved one goes into intensive care next week? But if they do go into intensive care, you need to contact us day one, because you can't take any chances in life or death situations. Okay, I'm going to wrap this up for today. Sorry for being late. Sorry that I couldn't go for the full hour, but next week I'm endeavoring to go for the full hour. If you have a loved one in intensive care, go to intensivecarehotline.com and call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com. Now, if you have a loved one in intensive care with ventilation, tracheostomy, unable to wean off the ventilator, also including BiPAP, CPAP, TPN, you should contact us as well for intensive care at home. You can find us at intensivecareathome.com. We are currently operating in all major capital cities in Australia. We are NDIS funded, but also funded through other avenues. You should contact us for any inquiries for intensive care at home, or you can email us to info@intensivecareathome.com. Also, have a look at our membership for families in intensive care at intensivecaresupport.org. There you have access to me and my team 24 hours a day, and we answer all questions intensive care and intensive care at home related. If you are looking for a medical record review, in real time when you have a loved one in intensive care, you should contact us as well. We can help you with a medical record review in real time in intensive care, but we also review medical records after intensive care, especially if you're suspecting medical negligence or if you have unanswered questions. Now, I'd appreciate if you give this video a like, subscribe to my YouTube channel for regular updates for families in intensive care, including the YouTube Live. Share the video with your friends and families, spread it far and wide, click the notification bell, and comment below what you want to see next or what questions and insights you have. Thanks for watching. I'll see you again next week or during the week with my quick tip videos. This is Patrick Hutzel from Intensive Care at Home and intensivecarehotline.com, and I'll talk to you soon. Take care.